Well, more seriously, I'm here for share with you my knowledge about osteoarthritis. And probably you know that osteoarthritis is a disease of the cartilage, which is directly related to aging. And more particularly after 45, the prevalence of symptomatic osteoarthritis increase and reach 30% after 65 years old. And what is very important is that the ratio of the people with 65 and more will drastically increase during the next decade. Therefore, osteoarthritis will be an important social and economical problem issue for the community. And this is for which we need for an efficient and safe, and this is probably the more important, safe treatment for osteoarthritis. I will now try to telling you the different steps, the different discovery in the field of OA physiopathology. Since a long time, osteoarthritis was considered as a mechanical disease resulting from overloading, overuse, after, for example, joint instability induced by a trauma, for example, or also a malignment of the limb, leading to the loss of cartilage. Secondary osteoarthritis was considered as a global disease affecting all the joint and the periarticular tissues, including the synovial membrane, which show inflammation, which is secondary to cartilage degradation, but which directly accelerate the degradation of the cartilage. This is for which we use NSAIDs in the treatment of osteoarthritis, is to try to control this inflammation. We know that subchondral bone is also directly involved in the progression of osteoarthritis, and this bone, which is just below the cartilage, show a different modification, including sclerosis and the bone marrow lesion, which is like an edema of the bone, which is only visible on MRI. The periarticular tissue also play an important role, including the fat pads, which directly contribute to the cartilage degradation by secreting a lot of inflammatory factors, but also factors coming from the fat tissue, named the adipokines. Ligaments show laxity, capsule retraction, which includes the pressure and the compartmental level of the joint. And finally, the muscles play an important role. I'm sure that in the next decade, muscles will be an important actor of OA. Why? Because muscles show atrophy, a decrease of the strength, but also a loss of the neuromuscular control. Well, then after, osteoarthritis was considered as a metabolic imbalance inside the cartilage. You know that in the normal condition, the metabolism in the cartilage is driven by a balance between the catabolism and the anabolism. The catabolism involves, for example, metalloproteinases like collagenase, glycogenase, which directly degrade the matrix continuance of the cartilage. But this catabolism is counterbalanced by the anabolism, which corresponds to the synthesis of the matrix component of the cartilage, including the two main components, aggregates and type 2 collagen. Unfortunately, in osteoarthritis, this balance is lost, and you have a very important disequilibrium between the catabolism and the anabolism in favor of the catabolism, which is characterized by a strong increase of the metalloproteinases and a decrease in the synthesis of the matrix constituent. And this disequilibrium is driven not only by mechanical stress, but also by a lot of inflammatory mediators, including IL-1, IL-6, but also products of the COX-2 and INOS enzyme. If we try to summarize all the biochemical process involved in OA in one chart, we can start by the mechanical stress induced at the cartilage level. This mechanical stress, for example, induced by a trauma of the joint, induces a lesion in the cartilage and activates the chondrocyte. Activate the chondrocytes to secrete a lot of factors, but mainly one, which is the IL-1 beta. IL-1 beta is a key cytokine which directly stimulate the chondrocytes to produce metalloproteinases, aggregationase, collagenase, and decrease the synthesis of the matrix constituents like aggrecan and type 2 collagen. Moreover, we now know that chondrocytes produce a factor which is called rankle. Rankle is an activator of the osteoclast, which by this way increase the activity, the bone resorption, the bone remodeling, and by this way contribute to create bone sclerosis. Recently, we have demonstrated that the osteoblasts coming from this area express a fully different phenotype than the osteoblasts coming from the non-sclerotic area. And they produce a lot of factors that can directly affect the surrounding osteoblast, but also the overlying chondrocytes which are present in the cartilage. We have demonstrated in my lab that osteoblasts coming from the sclerotic area produce pro-angiogenic factors like vascular endothelium growth factors, which stimulate the growth and the invasion of blood vessels inside the cartilage. And these cells produce also an inflammatory factor IL-6, which can directly stimulate the chondrocyte to produce more and more metalloproteinases. By this way, you have a vicious circle between the cartilage and the subchondral bone. And for example, these loops can be counteracted, and this was the hypothesis that was brought by people developing biphosphonate. They used biphosphonate to try to treat osteoarthritis based on the hypothesis that this drug could control the abnormal remodeling of the subchondral bone. Well, moreover, osteochondral fragments and microcrystals coming from the cartilage may also trigger synovial inflammation and activate the synovium cells, like, for example, macrophages or lymphocyte T, to produce more and more metalloproteinases and pro-inflammatory factors, which directly regulate the metabolism of chondrocytes and degrade the matrix. By this way, you have a second vicious circle between the synovium and the cartilage. And this synovitis can be, of course, triggered by NSAIDs. Well, more recently, and this is an important advance in the knowledge of osteoarthritis, is that osteoarthritis was considered as a metabolic and systemic disease of one organ, the joint. Why? Because it was demonstrated a relationship between underweight and obesity. And this relationship was not, of course, conducted by the overloading of the joint, but by the production of factors, and mainly what is so-called the adipokine. Adipokine, like leptin, play an important role to stimulate the catabolism of cartilage. Moreover, it was directly, this obesity and this fat tissue was directly related to what is so-called the metabolic syndrome, including features like hypertension, type 2 diabetes, or dyslipidemia. And recently it was demonstrated an association between knee and the metabolic syndromes, but also with each of the features of these metabolic syndromes. Well, how can we treat osteoarthritis, and what are the limitations of the treatment of osteoarthritis in 2014? At this time, the treatment of osteoarthritis required the association of non-pharmacological and pharmacological modalities. The non-pharmacological modalities include mainly patient education, physical and occupational therapy, but also weight loss. Unfortunately, these modalities has a poor compliance. The pharmacological treatment is dominated by analgesic and by NSAIDs. And this doesn't make sense at this time. And I will discuss with you why. Besides this NSAIDs and analgesic, you have a new class of drugs, what is so-called the symptomatic slow-acting drugs in OA, including Piascledine and, for example, also the glycosaminoglycan, like glucosamine sulfate or chondroitin sulfate. This class of compounds are characterized by their delay action. The efficacy of these drugs appear after 4 to 6 weeks of the treatment. Why to use NSAIDs doesn't make sense in the treatment of osteoarthritis? The first reason is that it was demonstrated by this meta-analysis performed by Zhang in 2010 under the auspice of the ORC, which is the unique scientific society focused on osteoarthritis. It was demonstrated that NSAIDs show an effect size which is very low and inferior to the effect size of the other modalities used in the treatment of osteoarthritis. This means that to use NSAIDs to fight the symptoms of OA is not so efficient because the effect size is an indicator of the magnitude of the effect comparing to the placebo. Moreover, we know that NSAIDs induce a lot of adverse effects. The conventional NSAIDs drastically increase the risk of gastrointestinal adverse effects, like perforation, ulcer branding, and so forth. Further, the COPCs are also directly associated with an increased risk of cardiovascular issues. Therefore, why to use NSAIDs in the treatment of OA, which is a disease directly related with elderly people, with aging, which show a lot of comorbidities, which are contraindication to use NSAIDs. In summary, we need of an alternative to NSAIDs. Why? Because osteoarthritis is a long-term progressing disease with an evolution in some decades. And we need to manage these symptoms during a long period of time. NSAIDs show a very low effect on OA symptoms. Moreover, NSAIDs are associated with severe adverse effects and show finally a high risk-benefit ratio. It was demonstrated iatrogenesis due to the overuse of NSAIDs, paracetamol, and corticosteroid infiltration, and this is for which we need to avoid this treatment is osteoarthritis. But well, we need of an alternative. And this alternative is Piascledine 300. What is Piascledine? Piascledine is a small fraction of oils coming from avocado and soybean, which a very specific and patented formulation, which is unique for this product, and which contain mainly steroids. And this compound is a well-known mechanism of action, and we have in Milet contribute to better understand the mechanism of action of this drug. How do we manage this task? By testing this product on human OA chondrocytes, which are cultured in hydrogenated beads. Why in hydrogenated beads? Because in this culture condition, chondrocytes remain chondrocytes and don't differentiate it in fibroblast. And by this way, we can test the effect of a product for a long period in culture, for 12 days, at least 12 days. And we have then tested different parameters, including parameters involved in the catabolism and involved in the inflammatory reaction. And we have clearly demonstrated that Piascledine decreases in a dose-dependent manner the production of nitric oxide, which is a key factor involved in the deleterious effect of IL-1 beta. Moreover, this drug decreases the production of MMP3, which is the stromatolin which directly degrades aggrecan. We have also shown that this drug is capable to decrease PGA2, but also pro-inflammatory cytokines like IL-6, IL-8, and MIP, which is a cytokine which is directly involved in the activation of macrophages. Well, by this test, this in vitro test, we have clearly demonstrated that the drugs may decrease the synthesis of metalproteinases involved in the degradation of cartilage and decrease also the production of pro-inflammatory factors which can be involved in the chronicity of synovitis. We have also investigated the effect of the drugs on the anabolism of the cartilage. And we have more particularly investigated the effect of this drug on the production of TGF-beta1, which is a growth factor that can stimulate directly the synthesis of matrix constituents. And what we have demonstrated is that Piascledine increased the production of TGF-beta and the production of aggregan, which I remind you is one of the main constituents of the cartilage. In summary, we have demonstrated that Piascledine can promote the production of cartilage through the release of a key growth factors, TGF-beta1. Finally, we have investigated if these drugs are capable to control the deleterious effect of IL-1, this very active cytokine to the cartilage degradation. To perform and to answer to these questions, we have incubated the chondrocyte with IL-1 during 3 days. And by this way, we have demonstrated that the production of aggregan is fully blocked. This is the green line. But when we incubate the chondrocyte with Piascledine, we have a progressive recovery of the aggregan synthesis, demonstrating that Piascledine is capable to counteract the deleterious effect of IL-1 on aggregan synthesis. Well, is Piascledine effective in animals and in humans? I would like to show you 2 slides summarizing the effect of trials conducted by a Canadian team on duck. In the first one, the researchers investigated the effect of Piascledine on 24 non-arthritic dogs which received in the diet either a low dose of Piascledine, 300 milligrams every 3 days, or a high dose of Piascledine, 300 milligrams per day. And they measure directly in the synovial fluid the levels of TGF-beta1 and TGF-beta2. And what they observe? They observe a strong increase of the level of these growth factors in the synovial fluid of a joint of this dog. What does this mean? This means that Piascledine is able to reach the joint tissues and to modify the synthesis of growth factors by tissue inside a joint. This demonstrated that really Piascledine targets the joint tissue. Well, then after, they have tested Piascledine in OA dog, in which the osteoarthritis was induced by the section of the cruciate ligament, creating an instability of the joint and a progressive overuse and wear of the cartilage. After 8 weeks, by histological analysis, they observed the appearance of osteoarthritic features in the cartilage, including fibrillation, fissuration, and also cell clustering. But what is surprising is that 8 weeks after treatment with Piascledine at a concentration of 10 milligrams per kilo, you have a full protection of the cartilage and the absence of appearance of these structural changes in the cartilage. Moreover, they demonstrated that Piascledine may control the production of MMP13, which is a key enzyme involved in the degradation of type 2 collagen, and also the expression of inos, the enzyme responsible for the synthesis of nitric oxide. Again, this demonstrates that piascledine can prevent the appearance of osteoarthritis in animal models, and that, indeed, piascledine reaches the joint tissue. Okay, now what's happened in human clinical trials? In 2008, Christensen's team published a meta-analysis including 4 clinical trials investigating the effect of piascledine on the symptoms, on the pain, and on the function of the joint. These 4 industry-sponsorized RCT included 272 patients with hip OA and 392 patients with knee OA, which received during 6 months 300 milligrams per day of piascledine. And what this meta-analysis showed is that the effect size, which I remind you, this is the magnitude of the effect of a drug comparing to the placebo, the effect size is clearly in favor of piascledine for the pain and for the function. I propose now to have a quick overview of the different clinical trials included in this meta-analysis. The first one was conducted by the Mayo team in France, including 164 patients with knee or hip OA. And this patient received either piascledine 300 milligrams per day or the placebo, and the patient was followed 2 months post-treatment to evaluate if the effect is yet present or not. The primary clinical endpoint was the change in the local functional index score from baseline to month 6, but also the change in the spontaneous pain and in the functional disability. Clearly, the study demonstrated that piascledine at a concentration of 300 milligrams significantly decreased the functional index, the local index, decreased the spontaneous pain, and decreased the functional disability. What is also important to see on this slide is that you can see that the effect is already significant 1 month after the beginning of the treatment, and that the effect of piascledine increased with time. And finally, is that the effect of piascledine remained even 2 months after discontinuation of the treatment. They have also evaluated the success rate. What is the success rate? The success rate is defined as an improvement of the local functional index over 30% and a reduction of the pain over 50%. These criteria are very severe and can be considered as a relevant clinical response in patients. And what you can observe is that the number of patients that reached this criteria, this severe criteria, was higher in the piascledine group compared to the placebo. And this rate continued to increase even after discontinuation of the drug. They also demonstrated that the adverse effect was similar in the piascledine group compared to the placebo group, and that any severe adverse effect was associated with the drugs. The second study investigated 160 patients which were randomized in piascledine or placebo group and which received the drugs daily for 3 months. The characteristic of this population was that all the patients took one of the 7 predefined ORNCs during the first half of the study, which is the period between baseline and 45 days, and continue, if needed, during the second half of the study corresponding to the period between day 45 and day 90. the primary endpoint of this study was the ratio of patients resuming NSAIDs therapy after and during the second half of the study. Clearly, they demonstrate that the number of patients resuming NSAIDs during the second half of the observation was significantly lower in the group of patients receiving Piascledine 300. And moreover, the concentration of NSAIDs, the cumulative dose of NSAIDs that patients intake during the second half of the study was decreased by half. This is a very significant result. Again, this study clearly demonstrated that Piascledine fights to induce severe adverse effects, and the recorded adverse effects were similar to those observed in the placebo group. This author concludes clearly that Piascledine 300 reduces the reliance on NSAIDs for pain relief in patients with symptomatic knee and hip OA. The last symptomatic clinical trials was performed in Belgium in collaboration with Professor Appelbaum. In this study, they include 260 patients that received either a high dose of Piascledine, 600 milligrams per day, or the recommended dose, 300 milligrams per day. This study was designed to demonstrate that the optimal concentration of Piascledine is, 300 milligrams per day. And again, the primary endpoint was the NSAIDs analgesic intake between day 30 to day 90 during the second half of the study. This study clearly demonstrated that the optimal dose to decrease and to control the symptoms in OA was 300 milligrams. Moreover, this study confirmed that Piascledine may save the intake of NSAIDs. They clearly demonstrated that the number of patients that decreased by 50% the intake of NSAIDs or analgesic was more important in the group of patients receiving Piascledine comparing to the placebo. More precisely, by day 90, the NSAID analgesic use dropped by over 50% in 71%, this is very huge, of the patients taking Piascledine 300 milligrams, compared to 36% patients in the placebo group. Again, in this study, after 3 months of follow-up, no adverse effect related to the drugs was observed. Well, if we try now to summarize the key message coming from these 3 symptomatic clinical trials. The first one is that the optimal concentration of Piascledine, 300 milligrams, reduced significantly the pain and improved the joint function. Secondary is that the effect of the drugs remained even 2 months after the discontinuation of the drugs. Finally, Piascledine contribute to significantly reduce the consumption of NSAIDs and by this way to control better the adverse effect in elderly patients. Now, the last question that I would like to address this evening concerns the potential structural effect of Piascledine 300. To evaluate if a drug is capable to control the progression of osteoarthritis, the modification of the structure of the cartilage, the gold standard at this time is the measurement of joint space width at the narrowest point. This is the gold standard on an X-ray. This gold standard was used in 2 clinical trials. In the first one, 163 patients with hip OA were treated during 2 years. This is a very long-term period with either Piascledine 300 or the placebo. And the clinical assessment, the primary endpoint, was the decrease in joint space width seen with radiography at the end of the 2 years follow-up. What did conclude is that if we consider the overall population, Piascledine didn't significantly modify the joint space narrowing. But if we only analyze the patient with severe OA which are considered by a joint space width at baseline inferior to the median baseline value of 2.45 millimeters, if we consider only this subgroup of patients, you can observe that Piascledine decreased significantly the loss of cartilage, the loss of joint space width. This is important. This means that Piascledine 300 acts on the cartilage structure in patients with the more severe osteoarthritis, hip osteoarthritis. Again, in this long-term clinical trials, no adverse effect, no difference in the number of adverse effects was recorded between the Piascledine group and the placebo group. These results were confirmed by a more recent clinical trials conducted by Emmanuel Maheu again. In this study, they include again patients with hip OA, and the patient received during 3 years Piascledine 300 or the placebo. And again, they record the hip joint space width and mainly the change of the joint space width from baseline to 3 years at the narrowest point of the joint space. And they considered also a secondary outcome, the comparison of the percentage of patients which are considered as progressor. A radiological progressor is a patient which undergo a decrease of joint space width superior to 0.5 millimeters. And what they observe, they clearly observe that the ratio of the progressor is significantly decreased by 20% in the group receiving Piascledine 300. This confirms that Piascledine is capable to slow down the progression of radiographic hip osteoarthritis. Well, it's time now to conclude. Piascledine 300 is a drug, a prescribed drug in France, with a unique formulation and well-identified mechanism of action. We have shown that Piascledine may decrease the catabolism, increase the anabolism of chondrocytes, and by this way, explain how Piascledine may control the progression of radiographic osteoarthritis. Piascledine has a strong clinical evidence, level 1A, and is recommended by the European League Against Rheumatism. This is an efficient drug on pain, but also on function, and this is the only one drug which is really active on the function of OA patients. Further, this drug may reduce the NSAIDs consumption in patients, and this is a key point because to decrease NSAIDs in the management of osteoarthritis patients is very important. Further, we have seen that these drugs may have a structural effect by slowing down the progression of radiographic hip OA. And finally, Piascledine is a safe product with no adverse effect and any interaction with other drugs. Thank you very much for your attention.